Morning. Hello, everybody. Here we are. Thank you. Thank you. Here we are again in a session of What Would You Do, Season 3, session number 7. My name is Maria Teresa Casaca. Not wanting to reveal a lot, but I'm an exclusive practitioner of endodontics with a microscope. And today I will do a presentation. First of all, I would like to ask you all to sign in on our YouTube channel, to ring the bell so that you can always know when we come live, to see everything that's backward, and to follow us on our social media. I'm going to present a case today, and I'm hoping to leave a lot of questions in the air after my presentation. So it is very important to subscribe so that we have follow-ups and that we know more and that we know the questions that were raised here, and some of them probably will continue, and a lot of discussion. That's one of the best things, and that's how we go forward. And that's what we need also, because science needs more than answers and absolute answers. I think science needs the questions. So today I'm going to present this case. This is a 30-year-old male patient, healthy, without anything of medical history, no non-allergy, that presented for orthodontic evaluation, and when the CT scan was performed, it was seen this apical lesion associated with tooth 27, very close nearby the maxillary sinus, with a previous endodontic treatment few years ago, without any clinical complaints, but it was a radiographic finding. And we placed some questions, and we discussed the options and the questions also with the patient. Options. Okay, we have a problem, so radical solution. Extraction. With this image, we spoke. We always speak together. We always speak between the team. And okay, let's go for a delayed implant placement. Other option, to solve the problem, the apical periodontitis. What about surgical retreatment? Is it feasible? Will we go there? Won't we go there? And what about non-surgical endodontic retreatment? And the votation of our audience was like this. A major solution for non-surgical endodontic retreatment, and in the same scale, extraction and delayed implant placement, and surgical endodontic retreatment. But as I spoke, and about questions and about science, in endodontics we have important societies. We have a lot of information, we have a lot of articles, we have a lot of publication, but we also have the support of two major endodontic associations, American Endodontic Association and European Endodontic Association. And this is a chart. This is even for the patient and for us and for referral dentists to know when a patient should be referred. And with this chart, including patient considerations up to technical issues, we can establish the degree of difficulty of a case. And every case which is a retreatment comes immediately in the high difficulty case. And so to think about doing the endodontic treatment with all the technical conditions that we can get. Because it is also important to say that many studies that we present and that we see are done under very good technical considerations, and that is what should be done and what is considered also. So, filling this chart, okay, a difficult case, but let's see. And we started by seeing the CT scan, and here I have a film of the analysis of the CT scan. As I told, the apical lesion and previous endodontic treatment, the endodontic treatment didn't seem to be badly performed, but we had, especially in the buccal roots, a large periapical lesion, periapical lesion, and a little extruded material also in the palatal root. And so we spoke to the patient, we explained him everything, and we decided to go for the retreatment. The retreatment itself, I won't speak a lot because even though this might seem to be the most challenging part in endodontics, this is the part that can best be trained, the procedure part. I would like to focus a lot on diagnosis and prognosis. But, of course, with isolation, and it is important to say that this patient, for example, when I place the rubber dam, what's that? And that already tells us a lot about where we began. So, access, I removed the old filling. There was no cracks, there was no fissures, nothing that was an indicator of any other degree of complication. I forgot to tell, but the periodontal probing was also physiological in this treatment. So removal of filling materials, patency and preparation, the final calibration of the canals. Afterwards, I'm sorry for the x-ray, in the charts, I don't know if you remember, in the chart of the American Endodontic Association, we have there a cross, and one of the things we can choose, it's gag reflex. Why? Because it can really make the case difficult, and this was a 27 and it was a reality. So after disinfection, activation of our irrigants, the filling, the sealing, and the endodontic treatment was only considered finished after the final restoration. That was done with Dr. Agatha a few days after. So this was the final, and then, okay, now let's go for the next stage. Next stage, for finishing the endodontic treatment, it's always the control stage, especially in cases of retreatment and especially in cases of apical periodontitis. The controls, the follow-ups are very important. It's something that we all feel it's difficult to explain to patients, especially in these asymptomatic cases. We were very lucky because as this patient was going for orthodontic treatment, he would come to the clinic, so he didn't have a really way to escape, to do the control, so clinically at least we always had him very well controlled, but he was already symptomatic, so if not, it is very important to explain this patient, controls must be done. And this is the CT scan of the 17 months follow-up control, and what we can see is not a complete healing, but a reduction in the opacity of the bone around the buccal roots, and a difference in the image comparing the previous and these CT scans. This is 18 months follow-up. So, what would I like to discuss from now on and after the clinical case and the what would you do, what would I like to discuss? I would like to discuss a lot. What I think it's very important in this case is that it's the follow-up. And this is not a young discussion. This discussion has around 40 years. So it's in the range of our ages, but it is a discussion that has come from a lot of time. Of course that with the CBT-CT, and we know it from the studies in dogs and already in humans, and we know we are seeing a lot of lesions, and we are seeing a lot of things, and we are seeing much more than we saw with periapical radiographs. But, and this is a study that was first published in 1986, based on periapical radiographs, with all the limitations that periapical radiographs have, especially in posterior teeth, multiradicular teeth. There was already a concern about the periapical status of our roots before, after, and in the follow-up periods of our endodontic treatment. And so this is a classical study. It's about the PI, the periapic index scoring, and it divides the periapical status in 5 degrees. Knowing that stage 1, that it's for sure no lesion present, and especially in teeth with endodontic treatment, this is a hard stage to get, till 5, that is the periapical destruction of bone, sometimes even with abscess and fistula. And of course, stage 1 and 2, it's more or less clear that our healthy periapical status. 4 and 5, okay, lesion. What about 3? And another thing, in multiradicular teeth, we always looked at the worst root, but we looked at the worst root, but as together because it was periapical. And of course, science as an evolution, CBCT is a reality in our days, and also this in CBCT. So this got more complex, but also more accurate. And now we have for all classes of teeth in an independent way and for all classes of roots. So we have a better scoring for apical lesions or for apical destruction, more than apical lesions. By now I would like to speak about apical destruction. And why is this important? This is important first because it is easy to see when we have a large apical region or when you have an apical abscess, acute, of course, or chronical, of course. What about those cases that we don't know and that we have a widening, where we have a root reabsorption and a widening? In some studies, not systematic reviews, not meta-analysis, there was an histologic diagnosis of those lesions, and there was a diagnosis that was defined as a periapical scar. That is, when they went to look in the microscope, it was non-homogeneous collagen tissues without bacteria. And it seems to happen more often when both plates, buccal and lingual or palatal plates, are destroyed. And so now, and for a long time, sometimes we speak about scars. What is it? Do we need to retreat? No, maybe it is a scar. Don't we need to retreat? What if it is not a scar? And for example, in a patient like this, if he comes up in a follow-up, I will keep him in follow-up at least until 4 years after retreatment. If in 4 years we have an apical lesion, a radiopac, that I think it's most likely to happen, a radiotransparent apical scar, very short, but in the apex, a widening of the periodontal ligament, I think it's what's most likely to happen. But it is very important to tell that patient, and it is very important to see all the history. Problem comes when we get referred patients and when we don't know. So there is a very important discussion about diagnosis, about also the history of treatment, how it was done. Because in most cases, we don't go for anatomopathology analysis. And this is also, and the follow-up, and this is a diagnosis until now. This is the most recent article I found. July 2024, it was the most recent article I found about this. And I just placed here this image because we have a lot of technology, we have all the diagnosis and the treatment. The treatment technology is already a reality, and it's already coming to us, and it's already helping us, and it's not leaving many questions. It's let's use it the best way we can. And the diagnosis technology, we must think the same, and we must also always explain our patients what we are dealing with, what we know, what are our doubts, and how it can affect, and what we will do. Because in Less Choice, it's from our information about prognosis, about success rates, about the sures we have and the doubts we also have, that the best treatment plan comes. So, thank you very much. I hope I raised